Yes, I can.
I was a pediatrician in my first life and then been doing dermatology thereafter, about 45 years at this. So my talk is going to be very clinically oriented over my experience over 40 plus years. I'm going to overview my basic pain management principles, give some case examples that potentially could be a source of discussion, and mainly talking about vascular lesion, vascular birthmarks being one of my main passions. If you look at controversies, the first thing is diagnosis. We've got to make sure we make the right diagnosis. Hemangiomas, we have lots of issues about propranolol and thank you, beta blockers as adjuncts. Port wine stains, what's the standard of care, when to start, how often to treat. Tuberous sclerosis, the role of anti-angiogenic adjuncts as well. But we're going to talk about pain management and anesthesia. So we use yellow light for the most part or green light for red targets. And my basic principles are as follows. Preparation, we have to prepare parents particularly for the procedure, keep the area calm, comfortable, and gentle and soothing. Distraction, what I like to call talk aesthesia. The use of sucrose in little babies is useful. Sorry, it's a little nervous here. The meds, nitrous oxide is useful, sedatives, blocks, and general anesthesia. And Yasmin gave a very nice review on general anesthesia. I'm going to be talking mainly about non-general anesthesia options. Before we discuss treatment, we have to always try to focus on what the goals of our treatment are, realizing that it takes multiple treatments for, say, port wine stain and hemangioma and other lesions before we get good clearing or optimal improvement. First year of life, we want to clear ideally before the first year, where we can really work with the kids without resorting to much of any anesthesia other than a topical anesthetic usually. In childhood, our goal is to clear by school entry. In a teenager, we just want significant lightening and normalization so kids can get through their teen years without too much trauma. So if you look at the various bingo board menu, talk aesthesia distraction, topical lido blocks I use a lot in kids and young adults, PO nasal sedation, sucrose, Benadryl, Valium, Versed, nitrous oxide is very useful again in cooperative kids and young adults. IM analgesia and IV sedation and general anesthesia. These are examples. Here's that little cartoon. You can see, ouch, only a few more pulses. This is a cartoon a patient did. I said 25 pulses, and you notice there it says 27. She was counting every single pulse. So, and this is general anesthesia when occasionally we need to use it. So I'm going to break it down into different time frames as to how I approach anesthesia. The first months of life typically is in office with topical, light sedation, occasionally hydroxyzine, Benadryl, some little Valium sometimes. 15 months to 5 years is the most challenging and variable. In office, topical, light sedation, rare GA. 5 to 10 years, we use a lot of bargaining. We talk with the patients, topical, light sedation, blocks, Pronox. In 10 plus years, we approach it similar adults with block sedation and nitrous oxide. So just a word about nitrous oxide, very useful for basically the youngest I've been able to effectively use it in office is about 5 years old, as you see here on the lower right there. You just do it as you would breathing and using a snorkel type. I kind of say you just pretend you're snorkeling. And we talked about general anesthesia. Jasmine gave a nice review, which I won't belabor because she really fine-tuned the issues that these are very short interval GAs, so you can't compare some of the studies which do talk about some of the significant developmental and emotional effects. So I rarely use it currently. I used it for quite a few years when I had more access to an operatory. Now I use it rarely, and I can do full face treatments using blocks with people who are able to do that, and cooperative. Eye pressure checks, we combine pressure checks. Now pressure checks can be done on awake infants without general anesthesia. So our current pediatric ophthalmologists are doing this without general anesthesia. A word about topical anesthetics. They're not all equivalent, as you well know. EMLA, which is over the counter, is a eutectic mixture, 2.5%. Many compounded forms. I often use a 23% compounded form, which gives excellent topical anesthesia. We can also compound it with other mixtures and best under occlusion for at least half hour to an hour. So when we break it down by ages, so 0 to 15 months, as I said, We prepare the patients to prepare their kids, calm, comfortable, swaddle. Parents in the room, I often, just like Yasmin showed, I have parents in comfortable positions that you see here with the parent who is able and willing to put up with the kid screaming and yelling at times. And if they're not with the program, they're not to be in the room because we don't want to be treating the parent, we want to be treating the kid. And as you see, some other gentle sedatives can be used orally. For toddler and childhood management, soothing words are helpful, imagery. We don't try to use the word pain. We'll use pinch, we'll use discomfort, we don't like pin pricks and things, but pinching is a nice way to put it. We distract anesthesia. Screens are very helpful. If we can do it with some kids who are able to watch a screen as we're doing it. Topical lidocaine. Lidocaine blocks. This on the lower right, there's a traumatic scar from a bite. We're able to sneak in some topical intramucosal lido injection to take care of that and very comfortably take care of a 5-year-old with a traumatic scar. And we use nitrous and rare GA, as I say. So here's an example of traumatic scars we did with topical anesthesia or a little intralesional or block anesthetic to do both a vascular laser and a fractional CO2. As you see here on the lower middle section there, we're able to do fractional CO2 resurfacing to remodel the scars there. So what about childhood, 5 to 10 years? We often bargain with these kids. And again, distraction screens, topical lidocaine, nitrous, and light sedation are very useful. Example, this was done all in the office just with ring block anesthesia and a little sedation with a little Valium to get this 12-year-old through this procedure. So teenagers, we use a full gamut of options: topical lidocaine and block, sedation, nitrous, distraction with screens and whatnot, and rare GA. And these were cases we all did under local anesthesia in the office. Just an example, just this little quick video here. And I show this because this was done, about almost 20 years ago, I think we did this. Let me see if, see if I can we get volume, any sound? The only reason I'm showing this is if you see her mouth, and I'll tell you, "I don't feel it," she said. So I had a 12-year-old who came in who was traumatized by previous treatments, and I showed him this video, and he said, "I want that." So sometimes the video and education for preparing your teenager or young person who's been previously traumatized can be very powerful, because if he sees a video saying it's not going to hurt, then they're going to be motivated to treat. So as we know, our post-treatment, as you see here, angiofibromatosis, this is again topical lidocaine, light sedation, and some anesthetic blocks. We're able to do her treatment. And again, this is in just a proximal thighs, and we're able to do this with topical anesthetic only, with pulse dye, a little fractional non-ablative, and multiple treatments for these red young stria. So just a summary for pain management and pediatric derm. First thing is recognizing and treating these patients early, particularly recognizing early expansive hemangioma before it expands. Laser treatment the first months of life, and if you talk to Roy Geronis, the first days and weeks of life, particularly for port wine stains, but also for hemangiomas prior to the eruptive phase is very useful. Use of beta blockers and other angiogenic inhibitors are helpful as adjunctive treatments. Combination lasers often valuable for complex malformation, scar revision, etc. And some nevi also can be treated very well, nevus votive, with just intralesional block anesthetic regionally. Just a quick plug for the Vascular Birthmark Foundation. If you don't know, is Linda here? Linda has been the chief proponent of this and has done an amazing job internationally. And this is at Roy's office. We do cases there, pro bono cases, people from around the world. We had somebody from Hungary, somebody from Trinidad that we treated, and challenging cases at UC, and we've gone to Vietnam to do pro bono cases. So that is available for anyone's interested. You can talk to me, and I'll get you set up with the Vascular Birthmark Foundation. And that's pretty much my talk for today.